Right. So we'll start. Right. So if you have any worries, you just tell me. Right. If you have any questions, you can just fire it up uh, from the time or itself. Right. So you can move on with the questions. So if you have any questions, you can ask straight away. So you can see the screen now. Right. Okay. So as in any other system examination, when you are doing CNS examination, you have to do the relevant general examination, and that would include the build. So whatever the case you are getting, whatever system you are getting, you have to generally comment about the build of the patient, general hygiene, and things like that, right? So even in CNS case, a thin emaciated patient might tell you the diagnosis. Maybe it's a patient who is cushingoid, right? With seizures of steroid overdose, might tell you that patient is on some sort of treatment with steroids, which may be a autoimmune cerebral disease, right? So general examination findings might help you in coming down to diagnosis, right? So one thing is the build, and then the posture, right? So patient with CNS problems will acquire different positions, like they may be having these dystonic positions, right? So we'll discuss as we go on those things. And then about the facial expression, right? So what are facial expressions? A patient may be depressed, so these facial features may indicate the patient is depressed, right? In a patient like Parkinsonism, where there is difficulty in initiating movements and reduce movements, right? The patient will have a fixed mask-like face. In the bottom feature, you see, it's like a Vesak Munak wage, right? So it just look like no smiling, you can't see any emotions, anger, happiness, pain, nothing will change the facial appearance, right? So it looks like a mask, it won't change, right? So that might give you a clue to the diagnosis, right? The facial expression. And then sometimes if a patient has a hemiplegia, that means half of the body is paralyzed due to some problem, stroke or something like that, then that half of the body will be smaller than normal. So in this, can you see this girl, right? So this the left half of the body is, so the face is small, and there's a facial asymmetry as well, right? So the facial appearance can give you clues to the diagnosis. So remember, observation is a very important part of examination. A lot of times when you are given a case, you just jump and examine the patient, start doing things without observation, right? So don't get to that habit. Take about 30 seconds to observe the patient. See what you can find from observation. What of physical science can be elicited by just observation, right? And then some patients have one of the other face can be hypertrophic than the other side. So you might think it is actually at other side is atrophy. So they can facial asymmetry due to one half of the body getting hypertrophy. There are common some people entire half of the body is larger than the other side. We call it hemi-hypertrophy, and that's one thing you have to be careful not to mislead with the hemiplegia, right? So this is actually congenital thing, hemi-hypertrophy. One half of the body is larger than the other half of the body. So you might mistake it as a hemiplegic patient. So keep in that mind, right? So asymmetry of the body can indicate hemiplegia, but not always. So you can ask that whether it was from their beginning, or it was something that appeared afterwards, right? So look at the facial expressions; it give you a lot of clues, and then about the position of the joints, right? The abnormal positions of the joints will give some clues to the diagnosis, like when there is some neurological problems, right? Now, when there is muscular imbalance, now this is a concept you have to remember, right? So at each joint, there are movements that take place in opposite directions. Listen to this carefully, right? So say the the wrist joint, there is flexion and there is extension, and there is adduction, abduction, right? And then you get the elbow, you get extension, flexion, right? And then in the fingers, you get flexion, extension, thumb, abduction, adduction. is internal rotation. Position, is opposition, right? And in the elbow again, so all the movements that take place in a joint, right, occur in two opposite directions, right? So each movement has an opposite movement as well, and out of them, one movement is always stronger than the other movement, right? So if you think the elbow joint, there's flexion and extension. What is more strong, flexion or extension? Think what your upper limb is. Which is the elbow joint, the flexion and extension. Flexion or extension is more stronger.
Flexion.
Flexion is more stronger than the extension, right? Flexion is more stronger than extension. In the wrist, it is flexion more than the extension. The fingers, it is flexion more than the extension. In thumb, it is thumb adduction. That is thumb. This movement is more powerful than this movement. In the elbow, so the shoulder joint, flexion and internal rotation. Supination or pronation, what is more powerful? Supination or
pronation?
Yeah, pronation is more powerful than the supination, right? So what happens is in normal healthy, you and me, because the brain is controlling the muscles, the joints are kept in the functional position in the balance between the agonist and antagonist muscle at the joint, right? So each muscle, the groups that are controlling a joint are being controlled by the brain. So one action won't override the other action, right? So it will be in a balance. So in the elbow, there will be balance between flexion and extension, right? Once you lose the upper motor control, if you get a stroke and you're part of the brain that controls the upper limb is being damaged, or say you got a spinal cord injury and then part of this limb is now the spinal cord is been cut and there's no control from upper brain to the upper limbs, then what happens? The control from the brain will be lost. Now what happens? The joint will acquire the position of the most strong muscle group, right? So what will happen? The joint will be flexed at the elbow because flexions are more powerful and there's no brain to control it. The wrist will be flexed because flexors are more powerful than the extensions. The fingers will be flexed because fingers are more powerful than the extensions. The thumb will be adducted like that over thumb. So thumb over the palm can make it, right? Adducted thumb. Or make adduction can make it adduction. But it makes me no omega, but called the adducted thumb. In the leg, what will happen? What will be the position of the leg? In the hip. There's flexion in both ends. Are the flexors are more powerful than the extensors or what?
Yes, sir.
What flexors or extensors?
Extensors.
Flexors, right? In the hip joint, hip flexors are more powerful than the extensors. Adductors and abductors are there. Adductors are the powerful, the abductors are powerful. What are more powerful? Adductors or abductors? Adductors, good. Adductors are more powerful. So if you lose upper motor control, hip will acquire the position of what? Flexion and adduction. Right. So flexion and adduction. That's why when the patient with upper motor neuron problem, if you lift them up with the axilla, how will the limbs will play position? The cerebral palsy by the upper motor neuron limb lower limb, upper motor neuron palsy in Babek, up axilla would be so them. Like scissor. Couple they could again. Right? Couple the because one leg go the other and the hips will be flexed as well. That's because adductors are more powerful than the adductors. Right? The knee joint, what is the more powerful joint position?
Flexion.
It's flexion. So knees will be flexed. And the ankle joint?
Plantar flexion.
Plantar flexion, right? So it will be plantar flex, right? So the lower limb will be adducted and flexed at the hip joint, flexed at the knee joint, plantar flex at the ankle joint. If there's upper motor neuron lesion, right? And then what happens? Because of that, it will remain in the position. So if you might note an abnormal joint position because of the muscular imbalance. Typically seen in children with spina bifida, right? in spina bifida, then in the lower limbs, the foot get everted, right? Plantar flex and forefoot adduction. What do you call this? What do you call this condition? The club foot or talipes. Club foot or talipes, right? This is due to muscular imbalance because there's a spinal injury there, then damage to the spinal cord controlling the lower limbs, right? So, unopposed action of the other group, the the joint will acquire the abnormal position, right? Here again, in Erb's palsy, when the C5, C6 trunks are affected in brachial plexus, then the limb acquire this position, typical position of adduction in the elbow, right? Pronation, flexion at the wrist, right? And like a Porter's tip hand, right? So, due to upper motor neuron lesions, you can have abnormal postures, or due to muscular imbalance, you can have abnormal joint positions, right? And what happens if you keep this joint in this position for long, it will get fixed in that position, right? So you can have abnormal joint positions. Again, that might give you a clue about underlying CNS problem, right? So look at the joints, how the joints are, right? And then they can have trophic ulcers. What are trophic ulcers? Trophic ulcers are ulcers that result from either lack of blood supply or cut off of nerve supply. So it can be in like peripheral vascular disease where blood supply is not there. Then the part of the skin supplied by that area will get necrose and get an ulcer there. And similarly, if there is no nerve supply, patient will not feel any pain. Because there's no pain, what happens? He'll go and injure himself without knowing. He'll knock on furniture. He'll cut himself with sharp objects because he can't feel the pain. So there will be repeated trauma and get ulcers, and those are called trophic ulcers, right? And those are also indicative of some neurological problems. So, and especially in a patient with a neurological problem, you look for trophic ulcers because that's a complication of a neurological problem, right? So don't forget to look at trophic ulcers, and generally they are seen at dependent sites where there is pressure, like back of near the back over the spine, because the weight of the body is applying there, or the elbows, the ankles, right, on the foot, right? So where the places where the weight of the body keep on pressing on the patient. Now, if you keep in a single position for longer duration, what happens? After a while, we feel pain, and then you change the posture, right? So if you sit in one position for longer duration, what happens? Due to the pressure, the blood supply is reduced to that particular part of the body, and then we feel the ischemic pain. So we'll shift a bit and then change our position so that the pressure weight of the body will not be on the same position for longer duration. But if you're not having sensation, what happens? You don't feel that pain. So it go on keeping the part of the body in the same position for longer duration, and that will interfere with the blood supply to that particular part of the body and then cause damage to the tissues and cause an ulcer. Right? That's what we call pressure sores or bed sores, right? So in a neurological examination, it's important to look for pressure or neurological sores as well, right? It's a common problem in children with cerebral palsy, right? Because they keep in same position and that causes skin necrosis. Is it clear? Any questions? Any questions up to now? Till in the inspection, right? Any questions? And then you have to observe the patient for abnormal movements, right? There can be abnormal movements. Commonest thing is habitual tics. The habitual tics again, they have no underlying neurological abnormality, but they do these movements, present movements like that, and then the characteristic feature is these movements increase in front of an audience, and when the patient is anxious and stressed, this movement become more. And you can't find it underlying neurological abnormality. So you call them habitual tics. Some people blink, right? Some people make faces like that. So, they are called habitual tics because they are not having underlying neurological problems. So they are not of any significant value, but they can have chorea, athetosis, bellismus, and tremors, which are suggestive of some neurological abnormality. Chorea, athetosis, bellismus, all are mainly due to the problems with basal ganglia, right? Chorea means sudden jerky movements, right? Not violent, semi-purposive, non-repetitive, jerky movements of the body. What's the difference in chorea and athetosis? What's the difference between chorea and athetosis?
Athetosis are more slow and rhythm movements than chorea.
Okay, good. Other differences? What are the difference? Part of the body involved? Limbs are there, generally seen limbs. This movement in the limbs. Which part of the body involves the chorea? Which part of the body involves the athetosis? The chorea is proximal muscles. Right. Same means dance killer can rheumatic chorea or intense chorea, rheumatic chorea, right? They mean more like the shoulders like that. Whereas athetosis is more like in the distal muscles, like that. The chorea is more jerky movements, more forceful jerky movements, where athetoid they are more like snakes, like rhythm movements, like she said, rhythm movement like that, right? And Ayana movement at rhythm movements. Yeah, more involved in the distal part of the limbs, whereas chorea is more involved in the proximal part of the limb, and they are more jerky movements. Athetosis is more rhythm movements. Bellismus is very violent movement like that, right? Very more violent than the chorea, sudden jerks, and then they make a noise also. With usually when the movement is occurring, they make a noise also on the mouth, right? They may sometimes they feel also that, and it can be on one side or on both sides. Only one side you call it hemibellismus, right? And then tremors, that means finer movements. You know all that finer movements of the fingers. Our check is you just ask the patient to extend the hand and then observe it, right? So you can have this that you have in exams as a the anxiety can cause it, right? And you can have two types of tremors. There are two types of tremors you can have. There are two types of tremors. Intention tremors and rest tremors at rest. That means when you're not doing anything, just ask the patient to extend the neck, extend the hand. If you observe it, then you can see the tremors, right? That is seen in anxiety, hypothyroidism, and even in Parkinsonism, right? And when cerebral disease, with the cerebral problem, when you ask the person to do something, they develop the tremor, right? Because the movements are coordinated by cerebellum. So with the cerebral disease, you get tremors when you're performing a task, right? So it's called intention tremor. So if you ask the patient to put on a button, then you start the tremors on, right? Whereas Parkinsonism, then you put the button, the tremor will stop sometimes. If they are at rest, but absent when you're doing this, right? So intention tremors are more like to be of a cerebral origin, right? So those are abnormal movements you see, right? So those are things that is look, and then you have what you call this skin changes, right? So there are some conditions in the skin which indicates an underlying brain problem. Am I going too fast? Is it too fast?
No, sir.
Right. Right. You can have neurocutaneous disorders where there is some skin conditions which will indicate there is an underlying neurological problem, right? So examples are, one thing is caffeine patches. Caffeine again, caffeine can coffee. Lake can milk. Milk. Good milk. So caffeine can coffee on milk. Kiri coffee part of patches. And අපේ බබලා kiri coffee part in this kiri coffee part in white people. In our pigmented people, you get a dark patch, right? So you don't go looking for caffeine spots in our children. But the important thing is they are very irregular, vary in size, irregular margin vary in size, right? Mainly distributed in trunk at kind limbs as well, and multiple in number, right? And this indicates underlying condition. What is the condition? Caffeine spots are seen in neurofibromatosis. Right? Neurofibromas. So this, and they can have problems in the brain as well. Right? So that if you see this in the patient, you have to think of underlying neurological problem. Right? And what is this one? This white spot there is what they call ash leaf spot. Ash leaf can ash leaf ash leaf spot. So it looks like a very hyperpigmented white color patch without pigment, right? Commonly seen in the trunk of the patient, and looks like ash leaf. Ash leaf is and again that indicates an underlying brain disorder called tuberous sclerosis. Don't worry about these terms for the third years, right? Just know the name. We'll see this. When you go on to the word, you see this, and then you remember them, right? So anyhow, remember that some conditions in the skin will indicate underlying brain problem. And then this is a birthmark, red color birthmark involving the mainly maxillary division of the trigeminal nerve, the supplying area of the trigeminal nerve, the maxillary division, and part of the ophthalmic division as well. Right? It looks like spot yellow color, right? So it's called portwine stain, right? It's a form of a hemangioma. Not actually hemangioma, it's a AV malformation, right? It's not a hemangioma, it's AV malformation. If you press this, the red part disappears and it becomes blanched, right? So this is again indicative of a underlying brain disorder, and this is what we call Stroujiber syndrome. Right? There is similar changes in the brain inside the meninges, and that can lead to a neurological disorder. You learn it as you go on, right? So if you see this, it indicates possibility of having some underlying neurological problem. And this is called a shrug green patch, ugly looking like usually in the back, low back, right? Again, it indicates of a tuberous sclerosis, right? So both these conditions are more common in tuberous sclerosis. Again, in this condition, in the brain, you get these tumors appearing, right? With all these neurological problems. And this one, hypopigmented patch, and when you prick that area with a pin, you don't feel anything. What do you think of that?
Leprosy.
Leprosy, yeah. Called Hansen's disease also. In the middle of what we don't call it leprosy because it's a stigma. Stigma is there. So Hansen's disease, Hansen's disease. Yeah, leprosy. If you see an abnormal patch, always check for sensation, right? If the sensation is lost, you have to think of leprosy. So what I remember is there are skin manifestations that might indicate underlying central nervous system disorder, right? So don't just go and start examining when you ask to CNS examination. Don't just jump and start examining the reflexes and things, right? So look around the patient, look for these physical signs. These will give you positive clues for the ultimate diagnosis. Okay? Any questions about that? For third year, don't worry about these names, right? Just these are shown you. When you go to what, if you see them, it might bring back the memories, right? So don't try to memorize them. The video will be there with you. You can watch them again at any time. But remember that. What you have to remember is that if you see an abnormal skin condition in the patient, think whether it is related to the central nervous system, some disease in the central nervous system. These are special ones that you have to think about. Okay. And then it's thickened nerves, right? Especially if you see a palpable that hypopigmented patch with anesthetic area, anesthetic hypopigmented patch, you have to think of leprosy, right? And in leprosy, you get the peripheral nerves getting thickened, and the easiest nerve to feel is the ulnar nerve, right? So here, the elbow, feel it. අපිට පොඩි කාලේ කරන්ට් වදිනවා කියලා ගහන්න වෙදන්ට අපිට ගහන්න ළමයි කරනද? ඔක අපේ කාලේ කරන කරන ළමයි. මෙතන just at the medial part of the elbow, right? Just at the medial here you can feel it, right? If you just roll it like that for the bone, you can feel the ulnar nerve, right? Normal people. So if you tap there, you feel a current running around the ulnar nerve distribution, right? So in a patient with leprosy, you can feel the ulnar nerve thick, like a cord. In the leprosy, the nerve become more thickened, right? So you can feel it as a cord. So if you see an anesthetic patch, always feel for the ulnar nerve, right? So what I'm highlighting here, there are a lot of physical signs that are not really neuro, right? But they give you some important clues to underline neurological problem, right? Is it clear? Any questions about that up to now?
Sir?
Yeah?
What causes chorea and acidosis?
Basal ganglia lesion. Lesion is basal ganglia, right? Basal ganglia problems. Right? So basal ganglia are involved in motor. Your motor functions are controlled by 3 systems of the body. Your motor movements, right? So you see, I want to pick up this phone, right? And go and pick it up like that, right? It involves 3 parts of the brain. What are the 3 parts? One thing is the motor cortex. Other one is
Cerebellum.
cerebellum. Other one is basal ganglia. Basal ganglia, right? So the initial the command that go and pick up the phone, that command comes from the motor cortex, right? And that command that generated by the motor cortex is sent both to the basal ganglia as well as the cerebellum, right? But the initial impulse generated by the motor cortex is more jerky, pendular, and crude, right? So crude message sent from the cortex, and what make it smoother and more precise is the basal ganglia. So basal ganglia make it more defined movement, which is originating from the cortex. So the corticostriatal pathways are there, right, in the internal capsule. So from the cortex, by the corticostriatal pathways, its message sent to the basal ganglia, and from the basal ganglia, it goes back to thalamus, and from thalamic pathways go back to the brain, right? So the basal ganglia is the one that makes the movement more finer, and cerebellum, cerebellum also get the message. So it's actually a monitor. It monitors the function, right? So when you say to pick up the phone, so doing that, it makes sure that the job is done properly. The movements are more precisely done, and then it give a feedback to the brain again by proprioceptions whether it was done accurately, right? So that means when you're picking up the phone, right, on joint proprioceptions, the message is sent back to cerebellum, and cerebellum analyzes the initial message and the message coming from the proprioceptions to assess whether the movement was properly done and make the corrections in the necessary, right? So cerebellum make the movements more precise, right? So that's how it happens. So when there is either of these problem part of the brain side problems, you can get motor dysfunction, right? So when there is basal ganglia problems, you get these abnormal movements like chorea and acidosis and ballismus. Okay, right? Any other questions?
Explain particular areas in
Chorea is
lesion?
mainly the chordate nucleus, and acetose mainly lentiform nucleus. Right?
Thank you, sir. Sir, in leprosis, why sir the nerves become so thick?
Because the nerves are involved in infection. The nerves multiply in these organs, nerve tissue. Right? So even some neck nerves, nerves, and even the the superficial peroneal nerve over the tibia fibula, you can feel. Right? So the nerves are involved in leprosy. That's why you get this ulnar claw hand, wrist drop in leprosy. Right?
Okay, sir. Thank you, sir.
Okay. Any other questions? Right. So remember, when you are given a system to examine, don't just jump into the system. There are a lot of things that you have to look around apart from the specific system. Right? That's really important. That's what I want to highlight here. Right? So remember, a lot of things are there to assess before you directly go to the system. Okay. Tell you on then. Any other questions? Right. Move on, right? Okay. And then when you go to the real general examination of CNS, first thing you to assess is the consciousness, whether the patient is conscious or not. What part of the brain is involved with the control of consciousness?
Reticular formation.
Reticular formation. Good. Where is the reticular formation?
In brain stem, sir.
Let's go here. Again.
Middle part, sir.
Yeah, it's a diffuse area, right? Now, if you say where the facial nerve nucleus is a group of neurons located in a particular area of the brain. You can localize, this is the place of facial nucleus. This is the place of the nerve nucleus. But when you come to reticular formation, it's not a definitely anatomical demarcated area. It's a diffuse area of neurons from the midbrain to the medulla. It's not a small area, right? So the diffuse area in the brainstem, and that controls the consciousness. So if something happens to the reticular formation, patient will lose consciousness, right? So the consciousness has nothing to do with the cerebral cortex. Clear now? That's why when you get a partial seizure, focal fits, you don't lose consciousness. If a fit is there involving only part of the upper limb or part of the lower limb, it's not generalized, then the seizure activity is mainly in the brain, cerebral cortex. So the reticular formation is not involved. So you don't lose consciousness. But when a fit is generalized, that means both limb, both upper limb, both lower limbs, face and the tongue, everything is fitting. That means the seizure activity has spread into entire brain. So the entire brain, the seizure activity is going on. So the reticular formation is also now involved. Then you lose the consciousness. Right? So that's why with the focal fits, you don't lose consciousness. With the generalized stitch, you lose consciousness. Right? So it's a function of reticular formation. Right? So that's why in this children is cerebral palsy, right? Cerebral palsy, they are actually conscious. These quadriplegic cerebral palsy patients, that means all four limbs are involved patients, quadriplegics, they are conscious. But they don't respond to the environment. They just lie down. They are conscious, but they can't do anything, think anything, see anything. They're just lying down. But they're conscious because the brain is gone. And the cortex, the cerebrum is gone, but reticular formation is intact. So they are conscious, right? So the consciousness is obtained by the reticular formation. And then when you ask consciousness, we talk about rational or oriented. One thing we assess is consciousness. We'll go detail to that. What is rational? Now you should be able to reason out something, right? That means, say you asking, why do you eat? And then you should say, because I'm hungry, or because I want energy. Why you eat if because I want, because I'm thirsty, that is not rational, right? Say what? So, that's called not rational, right? So you talk nonsense actually. So not rational. So you assess whether the patient is rational. That means he can think clearly. So rational part is which component? Yeah. The consciousness mainly in the brainstem. So being rational means you have to have a intact cortex and to analyze and think critically and give an answer. Right? So to be rational, your brain, the cerebrum, the brain cortex should be functioning optimally. So your rational answer, right? So if you SC rational that means not rational, right? So that is called rational, right? And then oriented means you talk about three oriented in
Time, place, and person.
right? Time, place, and person. What is my time? For time patient is oriented in time, place, and person. That means if there is no time, place, and people. Right? Time what time if the person says it is 1956, then he is not oriented in time. ಅದು ದಿನೇ ಕಾಲದಿಂದ ಸಮಕಡ ಅಪಣ್ಣ oriented ಮಜಂತೆ ಸುವರ್ಣ ಕಾಲ ಕ್ರೆಡಿಟ್ ಕೊರೋನಾ ಇಂದ ಸಮಕಡ ದಿನೇ ಹೋ oriented ಸಮಕಡ right but disoriented called disoriented because of the being home and all the time and can't seem to have that problem, right? So if person can't have no idea about, if she says I am in the 19th century, that means he is not oriented in time. Then how to check whether he is oriented in place? You ask where you are, මම දිව්‍ය ලෝකෙ ඉන්නේ කිව්වොත් එහෙම නැත්නම් මම දැන් ඉන්නේ ඇමරිකාවේ කියලා කිව්වොත් එහෙම, then he is not oriented in place, right? So you ask what date it is, what time it is, that is oriented in time. Place means you ask where are you, where are you now? You say I'm in the hospital, am I talking to doctor? That means he's oriented in the place. And then person means you can have person in two ways. You can ask who you are. එයා කවුද කියලා. එයා කවුද කිව්වොත් එයාට එයාගේ නම කියන්න පුළුවන්. නැත්නම් මම නාත දෙයියෝ කිව්වොත් එහෙම මම කාලියම්ම කියලා කිව්වොත් එහෙම then that means he's not oriented in person. Or if you show somebody known to him, say you show him his father and ask who is this, and if he say this is my son, then he's not oriented in person, right? So that's what we call about oriented in time, person, and place. Okay, so which part of the brain is involved in time, person, and place orientation? Which function of which part of the body are you talking about? Which component of central nervous system we are checking by checking the orientation? Which component of CNS? Come on, anybody? What part of the brain are we checking? We need to check orientation. The brain cortex, right? So for you to, you should have memory, you should have reasoning, right? For you to be oriented in time, person, and place, right? So taking the function of the high function of the brain. In a proper way, it's called high function of the brain. So if somebody is having something encephalitis or in some problem with the brain matter itself, then you will have problems with the orientation and being rational, right? But consciousness may or may not be related to the cerebrum. That's the important to assess the CNS level of consciousness and the orientation. Okay, yeah. Any questions about that?
Sir, in disoriented people, so what kind of lesion can we suspect?
Simple thing is having some alcohol. අරක්කු වගේ බිව්ව නම් එහෙම, right? කියන දේ දන්නවද කියලා? Your friends would have had this, no? Because intoxication can cause this, right? Encephalitis can cause this. Okay, frontal lobe tumor can cause this, right? So it's something derangement of your cerebral cortical function. right? So best example is alcohol intoxication, right? Become loss of rational and oriented.
Okay, sir. Thank you, sir.
තාත්තට මතන් කියලා කතා කරලා ගිහලා දෙකක් දාගන්න පස්සේ okay. Then that is orientation, and then we have checked the level of consciousness, right? How conscious the patient is. So it can be normal or drowsy. Drowsy means he's conscious, but he feels sleepy. He can't keep up. He always fall asleep. Like in lecture halls, you see these patients, right? Or if you take some alcohol, you'll find this, right? So they are conscious, but the wakefulness is less. So they become drowsy, right? So they can't keep their conscious status, the awake status, not conscious, awake status. They find it difficult to maintain their awake status. That is drowsy, right? So what are the conditions you think of in drowsiness in a patient? What are things you think of? Can you think of conditions? Drowsy? In CNS infections like meningitis, encephalitis, again, drug intoxications, alcohol intoxication, right? Increase intracranial pressure, right? All those things can cause drowsiness. Or metabolic syndromes like renal failure, liver failure, which cause neurotoxic chemicals to accumulate in the body, then patient can become drowsy, right? So that is decrease ability to maintain the alert state, drowsiness. And then we called stupor. Stupor means you can't intelligibly or logically understand the thing. So you try to explain something to a person, but he can't understand what you're talking. But it should be able to understand. Black holes are anyway. Black holes are Einstein is apexta. So it's too much for your brain capacity, right? But you expect that person to understand, like say, either නැගෙනහිරින් පායනවා කියන එක අර පැත්තෙන් පායනවා කියන එක ලෝකේ බ්‍රවුන් කියලා පැහැදිලි කරන එක. So if you can't explain something like that, right? So that is called stupor, right? So when somebody is passing down the unconsciousness, they go to drowsiness, stupor, and unconscious, and then coma, right? So this is a stage of CNS alertness between unconscious and drowsiness. Okay. So you lose the capacity of rationalizing things, right? And then you have unconscious patients and you have coma patients. What is the difference between unconsciousness and coma? Unconscious means transient period of loss of responsiveness to the environment. Right? Unconscious patients will not respond to the environment. Right? When you call them, they will not open their eyes. They will not respond to their painful stimuli sometimes, right? So they lack the ability to respond to the environment. That is what you call unconscious, right? But unconscious means the period of lack of response to environment is short. But when the period is prolonged, you call it a coma, right? So that is the degree of level of consciousness you classify according to that. Any questions about that? You will find the words when you work in the words: stupor, drowsy, unconscious, coma. So you should know what the meaning of these words, and you should be able to tell the patient's condition according to these classification. Whether it's in stupor, whether it's in unconscious, coma, drowsy. And how do you measure the level of consciousness? That's the important thing, right? So if a patient is unconscious or decreased level of consciousness, you should be able to tell how much he is unconscious, right? For that, we use two scoring methods. One thing is called Glasgow Coma Scale. You would have heard about it already. And then there's other one called AVPU system, right? Glasgow Coma Scale is an objective one where you can give a score. Whereas AVPU system is a subjective one where you can't give a score, but you tell just some description, right? So, have come across this term Glasgow Coma Scale in a physiology? Yes. Neural Glasgow Coma Scale.
No, sir. No, sir.
No,
No, sir.
So Glasgow Coma Scale is the coma score that we use to assess unconscious patient to tell the degree of unconsciousness, right? How much is unconscious? The score, we can calculate a score, and that might give an idea how much is unconscious. So unconscious patients are not all same. There are degrees of unconsciousness, right? So that you can measure with the Glasgow Coma Scale. That's the measurement of the degree of unconsciousness, right? And then there are three components in the Glasgow Coma Scale, right? And those are opening of eyes, best verbal response, best speech response, and best motor response, the movements response. Right? So three things you assess accordingly. You give a score to each one, and then you have final score, right? So if you go down, I'll just show here, right? So these are three things we assess in Glasgow Coma Scale. One first thing is eye opening, right? First thing is you check for eye opening and whether patient opens eyes spontaneously, right? He keeps eye open, he opens eyes without you telling him to open his eyes or making any stimulus to open his eyes. He opens eyes spontaneously. And if he does that, you give 4 marks. For eye opening, there are 4 marks, 4 score, right? So if opens spontaneously, you give 4. If he opens only when you call him and tell him to open the eyes, right? And then it's 3 points, right? If opens only to painful stimuli, then you give 2. If it doesn't open at even for painful stimuli or any response, then you call it, give it 1. So remember, it's not 0. That's the important thing. Remember what Glasgow Coma Scale, each component, it's not 0. So it's 4, 3, 2, and 1, right? So open size spontaneously. So patient size opens eyes spontaneously, call it 4. If patient opens his eyes when you talk to him, then it's 3. If he opens eyes only when you cause deep pain to the patient, then it's 2. Whatever you do, if patient doesn't open eyes, you call it 1. Right? And then that is eye opening. Then what is the best motor response of the patient? That means movement. In the movements, if you ask him to raise the head, he raise the arm. If you raise his arm when you ask him to do it, and this obeys command, then it is 6. There are 6 components in the motor response, right? He obeys the commands, right? And then to make a painful stimulus, right? Say you pinch here, he'll bring his hand and try to take your hand away, right? So if you make a painful stimuli, then he will try to touch the stimulus and take it away. That is localizes the pain. That to give 5 marks. Stimuli, he can localize it, but he moves away. To avoid the pain, he moves away and flexes and moves away to avoid the pain, not localizing the pain. Then you give it 4 marks. And when you give painful stimuli, he just do like that, flexes, but not moving away from painful stimuli, not localizing the pain, just get stiffened like that. Decorticate position like that, right? Fixes like that. Then you give it marks 3, and when you give painful stimuli, it extends like that, not flex. Limbs are extended like that. then you give it 2. No response, you give it 1. Right? So again, you give a score according to the motor response, and then you have verbal response, the ability of the patient to speak. And if you speak in oriented, normal place and oriented place and time and person, then you give it 5 marks. Right? But he can talk, but he is confused. He is not giving the appropriate answer to the question. He is giving some answers, but not to the question is asked. Right? That is confused. That you are telling clear answers, but the answers are not for the question. Then you give it 4, right? And then he makes some voice noise words, and words are not appropriate. Inappropriate words, right? That is 3. And then he make noises, but they are not words. They make some noises, but the noises are not words. Then you call it 2. If there are no response, you call it 1. Right? So for each component, you give a mark. Say it is 4 here, it is 5 here, this is 4 here, then it is 12. So right. So for each component, you give a score, and then add them up, you get the final Glasgow Coma scale. Go right, Glasgow Coma score. This is what you call Glasgow Coma scale, and what you get is what you call the Glasgow Coma score. Right? So we have a score there, and in children above 5 years, you can use the same score. But children who are under 5 years, you can't use this. You have to modify Glasgow Coma scale for children under 5 years, right? So remember that. Children over 5 years use the same Glasgow Coma scale, but children under 5 years use the modified Glasgow Coma scale. Right? So, what are the importance of Glasgow Coma scale? One thing is you can monitor a patient. When you're monitoring a patient, you can check whether he's improving or deteriorating. Right? So if the patient had a Glasgow Coma scale of 13 on admission, and 2 hours later when you go, you find Glasgow Coma scale is 10. That means Glasgow Coma scale has decreased. That means he has deteriorated. Whereas Glasgow Coma scale was 8 on admission. Say diabetic patient comes in coma, his Glasgow Coma scale is 8. After treatment, the Glasgow Coma scale becomes 13. That means Glasgow Coma scale has improved. That indicates the treatment has worked. Right? So like that, you can assess the improvement or deterioration with the Glasgow Coma scale. Right? And then the magic number is 8. Number 8. Glasgow Coma scale of 8. Why it's important? And somebody know what is the importance of Glasgow Coma scale of 8? What is the importance of Glasgow Coma scale of 8?
If TCA is less than 8, these patients can't maintain the airway. The tongue may fall back and obstruct the airway. And also their gag reflex is absent and they can aspirate.
Very good. So Glasgow Coma 8 is a magic point where any patient with Glasgow Coma below 8 has a risk of aspiration mainly. The tongue falling backwards can happen in any unconscious patient at any level, right? Even in both that even it can happen. So any patient who is drowsy and having decreased level of consciousness can have the tongue falling backwards and obstructing the airway, especially after 8, right? And more importantly, after 8, they have lose the cough reflex and the gag reflex. So secretions can go in and aspirate into the lungs, and that can cause death. Right? So if a patient is having Glasgow Coma scale below 8, it's an indication to protect the airway. Right? So how do you protect the airway? You have to put a endotracheal tube. This is called an endotracheal tube. You put this into the trachea, right? Endotracheal tube, and it should be a cuffed endotracheal tube. Right? There's a cuff at the end of the endotracheal tube, right? This one you don't have a cuff in the endotracheal tube. There's a cuff there. With this end, you can inflate it by injecting air into the tube. A tube එකේ මෙහෙම දිනනවා බටයක්. ඒ බටේ මේ එන්නේ මෙතනට ඇවිල්ලා තියෙන්නේ. So මේ බැලුමේ ගහලා තියෙන කොච්චරක් එයා දාන්න ඕනද කියලා. මෙතන ගහලා තියෙන කොච්චර දාන්න ඕනද කියලා. So that you put the tube inside and then you inflate the balloon. So the balloon will stay in that place. Two advantages: it won't come out accidentally, and it will prevent secretion going down into the trachea. Right. So those are two advantages of having cuff endotracheal tube. In children, generally we avoid cuff endotracheal tubes up to about 6 years of age. Right. Under 6 years, you put this tube which has no cuff, without a cuff. But older ones, we use the cuff tube. But in situation where Glasgow Coma scale is less than 8, you have to consider putting the cuff endotracheal tube to prevent aspiration. Right? But nowadays there are modern endotracheal tubes with cuffs which are not causing pressure in the airway and causing damage to the airway. So there are modern endotracheal tubes which are safe in children with the cuff. If you got them, you can use in children under 6 years also. But if you don't have them, you have to generally go for an uncuffed tube. But the aspiration, you go for a cuff tube. Right? Is it clear? So this is what you call endotracheal tube. So this goes into the trachea, and this black line, you put the tube down until this black line passes to the vocal cords. Here are the black line until this part, up to this point, should be below the vocal cords. This part should go below the vocal cords, and you connect this end to the ventilator. Okay. So that is the Glasgow Coma scale. And then AVPU system. Now the Glasgow Coma scale is difficult to remember. And in the panic in the ICU settings or ETU setting, you might forget the score as well, right? And then it takes time to calculate it also. So quick decision making, you might not be able to use it, right? So they have devised a easy method of scoring the unconsciousness, which is called AVPU system, right? Yeah, A is for alert, that is patient is alert and responding to the environment. Then a patient is not responding spontaneously to the environment, but respond only to the voice, then you call it V, right? A patient is not responding even to the voice, but only to the pain, then you call it P. Patient not responding even to the pain, then call it unresponsive, right? So if you take the Glasgow Coma scale and AVPU together, the Glasgow Coma scale 8 corresponds with the pain. So if she is not responding to pain, that indicates you need to go and protect the airway. Right? So it corresponds to the point of 8. P is corresponding to point of 8. Right? So that's the importance of AVPU system. Right? That is the general idea about the central nervous system examination. Right? So then we have to go about the gate. Do you want to stop or continue? Praveen? Are you tired or? I know this is. Huh?
I think it's enough for that.
Okay, that's good. No, this is a difficult area. See, it's a difficult area. You have to understand that, right? It's something difficult to understand and difficult area to grasp as well, but it's an important area, right? So again, we'll stop it here. I think it's too much otherwise. A lot of new things are going in, that's why. So we'll stop it here and we'll do the gate and so see it next time, right? Any questions from today? Any questions you want to ask? All right. In that case, we stop it here and we'll discuss the next day, right? Okay.
Thank you, sir.